Today, what I wanted to talk about today is a shift in financial responsibilities between patients and healthcare plans. Welcome to Med Practice Made Perfect. I'm Tom Mahar with Practice First Medical Management Solutions. My name is Tom Mahar. I have run Practice First for the past 26 years. We specialize in RCM management, revenue cycle management, for physician practices, labs, etc. I'm a New York State CPA. I have been doing this every day for quite a while, and understand that some of the challenges that practices, physician practices, their practice managers have as far as getting paid what they deserve. So, back in 2004, through the Medicare Prescription Drug Improvement and Modernization Act of 2003, there started to be a more significant shift in responsibility of payments from insurance companies to patients. So, when Obamacare came on the scene in 2010, deductibles were typically in the range of $500 to $1,000. And as we've gotten into 2022 today, we're into thousands of dollars with, gold, silver, and bronze plans. So that's, really created a problem for, especially practices that have been around for a while that, we're not very quick to change and adapt to this shift in financial responsibility. So, HSAs, of course, have been created, and a lot of folks, fund these and pay all their medical expenses through HSAs. But regardless of whether they have HSAs or not, the bottom line is the burden is shifted to the patients. So, very simply, the old way of doing things used to be, the patient would come in the office, we collect a $10 or $20 copay. We provide the service to the patient, say goodbye, schedule the next appointment, and, we're on our way. The claim gets filed, the claim gets paid, the adjustment gets taken. We apply the copayment that was received, and, we go from there. Everything's fine. Hardly any patient responsibility at the end in that type of situation. So, today it's, of course, much different. So, the patient comes in, and depending on where they are at in their high deductible plan for their fiscal year in their plan, most of them reset January 1st. Not all, but most companies start January 1st. So it's really, critical at the beginning of the year that instead of just going and collecting copayments, what we really want to do is we want to take a look at and see, where's the patient in their high deductible plan so far this year? So, a lot of folks, a lot of different insurance plans, there's different ways to check these things. Many insurance plans, you just go to their website. These are, of course, participating insurance carriers that you're working with. And, you go to their website and put the information from the patient, and you'll see, you can get a very quick read as to where they are in their high deductible. So, that all sounds well and good, but the next question is, how much money do I need to collect from the patient? And, that can be a very tricky calculation depending on what type of specialty you have. So, let's go through a relatively simple example. Let's say that we have a primary care practice that's a fee-for-service practice. It's not a capitated practice. And, the patient comes into the office. They're going to have a regular evaluation and management code. Let's say that it's a level 3 or a level 4. Real easy, for the staff to say, look at it. If it's a newer established patient, level 3 or 4, and it's for, insurance company XYZ, it's real easy for us to find out what the allowed amount, what that carrier is going to allow. So, a simple example would be, a new patient, level 4. Let's say that the carrier pays $125. We know that, once that patient walks out of the exam room, assuming your provider has coded this claim already, we know it's a level 4. In that instance, all we would do is we would collect $125, and we would go from there. We're going to file the claim with the insurance carrier. The claim will come back with an allowed amount of $125, and at that point, long story short, I mean, the claim is, the encounter is going to be at zero. There's nothing to collect or refund, from or to the patient. So, in that instance, those are fairly easy examples. The same thing would apply on an established patient, obviously at a lower dollar amount. So, where it gets a little bit tricky is when we have specialists involved that might be doing multiple CPT codes, multiple procedures, or multiple tests. And, we don't want to get into a situation where there's tons of calculation to be able to figure out on the way out the door what that patient owes. So, really, the easiest way to do this, what I found over time is the easiest way to do this is to, of course, specific to your practice, is to, go through and determine, well, what is my average new patient? What is the average out of pocket for my average new patient? What is my average amount going to be for my average established patient? So, as long as we don't have tons of different procedures involved, that's relatively easy to do. Where we come up with just an average dollar amount, and then we're going to, assess that patient on the way in the door. Maybe we say, if it's a little bit more of an intensive practice, there's, testing that's going to be more expensive. We might charge that patient $200 or $250, before they get back for their tests or for the exam, and then basically tell them after the fact, we will, we'll settle this up basically once the carrier processes the claim. And once that carrier processes the claim, we will apply that, $200 or $250 payment that we collected up front. And then, basically, bill them the balance that's still owed, or refund them the money that might have been overcharged. So, this latter example of establishing a dollar amount for, new patients and established patients, it's a lot cleaner for your front office staff. The one thing, when you try to start billing folks, based upon, what was actually done, right then and there, it really assumes that, your provider is coding that claim while they're in the exam room, or they, have a scribe that's, doing this for them, or something along those lines. And that is pretty difficult to do, especially when there's multiple CPT codes involved. So, the general idea here is that I've seen many practices that don't want to address this financial responsibility with patients. And I can tell you, I mean, that is a grave mistake because it causes really a few different issues. And the biggest issue is that, if you've got to chase the patient on the backside, it is costly. And, I can tell you that, you're going to receive a lot less yield on each of your visits than you would had you not addressed this and faced it right up front. So, how do you do that? I mean, what's the motivating factor to really improving the financial health of your practice? And really what it boils down to is that, really two main things I think it boils down to is that, the first thing is that, the folks that are in your office that are greeting those patients, those are some of the most important patients or the most important employees in the practice, and outside of the medical care, of course. But the reasoning is that it's like any other business. You go to a business, you want customer service, so you want to be greeted by a smiling face. You want to be welcomed. It's very important if you have the right outgoing person at the front desk that is greeting folks. And depending on the size of the office, it might be a different person on discharge. But depending on what your policy is and which route you decide to go as far as collecting money up front, it's getting money out of that patient with a smile on your face before they get back to the exam room. Assuming you go with a situation where, you say, well, look, the new patient's going to be 125, established patient's going to be 75. That's the rule. That's it. You don't get back to the exam room until till you pay. So, probably the hardest thing involved with it is it's changing a behavior that, has been, really ingrained, especially in folks that have been going to the doctor for a long time. They were conditioned to, paying, $10 or $20 for many, many years. And then we had to shift to this, this idea of more and more money being asked for from the patient. And, many of them still have not, adapted to it. I can tell you, for many, many years, long before high deductible plans, one of the things that we would do in our practices is we would look at the idea of remember the Medicare deductible. So we have the Medicare deductible every year for folks that are straight fee for service Medicare. And, the numbers used to be, well, the first $100, hits the deductible. So what we would do is certain practices that were not real cash flow dependent or weren't too concerned and had enough cushion in their practice. What they would do is we would just hold these claims. So, the first month of service, the first month of the year, all the Medicare claims for January, we would just hold. Normally it's, we are not going to be the only provider, the only medical service they're going to seek in January. So we might hold all the claims till the end of January, middle of February, and then release all the Medicare claims. So, okay, what does that accomplish? Well, somebody else got stuck with, chasing the patient down for the deductible. So, in today's day and age, it doesn't sound like a whole lot. Back then it was a relatively big deal. It's the same sort of idea here. We'll see, today we see many cases where, patients at the very beginning of their deductible, they're going to go into a healthcare facility for a surgery, and, the surgeon will wait until, the facility has sent their claim in. So the facility sends their claim in. Maybe it's a $3,000 deductible, their bill is $10,000, whatever it is. The facility gets stuck chasing that patient down for the financial piece that relates to the patient. The surgeon sends their claim in, end of January, middle of February, whatever. The nice thing is they can, depending on how much work you want to do on this. And some people are very serious about it and will not submit the claim until that deductible has been met. They'll hold the claim for, 25 or 30 days, go check the site. Yep, patient's met the deductible. At that point, they'll file the claim. So not everyone is in that financial position to be able to do that, but that would be a strategy that you could employ to to try to combat chasing large dollars from patients that might not have that money available. There's other situations, and of course you've got to check all of your participating agreements that you have with your insurance carriers to make sure you're not breaking any rules as far as how you choose to bill the patients and at what time you go after these funds. So I've seen situations where they don't want you to hold claims for too long a period of time because of timely filing. You've got to watch out anyhow. Some carriers have timely filing limits of 90 days. You've got to have the claimant in 90 days. So certainly you would have to bill, and you wouldn't want to get too close to that to jeopardize your funds. So, those are, a few ideas as it relates to the timing. And one of the things that is important beyond the insurance, participating in insurance contracts is, you've got to check with state and local laws are different all over the country. When we get into financial policies and things of that nature, you've got to make sure that you're within the laws, not just the federal laws, but of course the state and local laws that might be applicable. Thanks for listening to Med Practice Made Perfect.